on your findings, first of all, it's a really nice presentation.
Oh, thank you.
Congratulations for
Thank
the
you.
hard work.
Thank
I
you.
really
Thank you
appreciate
so
that.
much. Thank you so much.
I just want to ask you, based on your findings, can you segregate the patient population of melanoma, those with metastatic stage, with high expression of RAGE, without, with low or no expression of RAGE? Is it possible, or?
Yeah, is it possible? That's what gene array Dr. Lekla and Dr. Vetter did on 40 human melanoma patients, and they have actually assessed only mRNA expression level of the lesion. Or else you can do tissue microarray studies.
So does it show that
Yeah,
the patients with the metastatic stage show higher,
Yeah.
patients with no metastatic
Yeah,
show low?
stage 4 melanoma patient showed higher RAGE mRNA expression as compared
Yeah.
to stage 3. So yeah, stage 4 is metastatic tumor. So yeah. Yeah, sure.
Curious question. I noticed your S100B concentration was in nanomolar,
Yeah.
while your RAGE concentration was in picograms per milliliter.
Yeah.
So if you convert them to same unit, either nanomolar or picograms, what's the relative ratio between those two?
Okay, let me see. I can calculate first.
You don't have it here, but if you have done the calculation.
Picogram per, actually picogram per mg of total protein, and which is in range of 1000 picogram, and if I times power 9, there will be a 100-fold less range as compared, approximately 100-fold.
So which one would be higher
Which one would be higher?
So that's what I was trying to think as you.
Picogram per mg of total. Seems like actually RAGE we have transfected, so we know RAGE expression was 1000 picogram per mg of total protein, which led to upregulation of S100B to nanomolar level. Usually in human beings, S100B levels are in picomolar actually. Normally, S100B levels in the blood of melanoma patients is in picomolar. But here we got nanomolar because it's patient has lots of blood, it gets diluted, but here since we have tiny dish, everything we have collected, therefore we got nanomolar. But the question you asked, I don't think I have answered it. Picogram per mg of total protein. Seems like RAGE is high. RAGE is high. No, seriously, RAGE is high. But I haven't calculated.
Then another curious
Yeah,
question.
sure.
Somehow I was expecting to see a higher response to the tumor volume decrease by your anti-RAGE antibody.
Okay.
It's, what you showed is with your, when you treat the mice with anti-RAGE antibody, tumor volume increase is less compared to the control.
Yeah.
Right? But it's still increasing.
Yeah, it's
right?
still increasing.
And I was trying to think through, is there anything known that the RAGE expression is dynamic at different stages? If you try to block the RAGE expression, the cancer cells will activate other pathways to mitigate that effect?
Actually, I have not come across such a direct study, but as I have shown that as RAGE ligands accumulate, RAGE expression has shown to be increased. That has been shown that RAGE ligand, as the RAGE ligands are accumulating, and in case of the anti-RAGE antibody treatment, I think why we are not seeing a complete suppression in the tumor growth, because there are other factors also. There are so many factors. First of all, RAGE has, as I have shown, induced angiogenic factor inside the tumor. RAGE has induced so many ligands inside the tumor. Therefore, this tumor microenvironment is also governing the properties of cells inside the tumor. So therefore, all these factors have become very complicated. We cannot say that blocking RAGE with anti-RAGE antibody will inhibit all the signaling pathways. So,
Can you really say RAGE is a specific biomarker for melanoma?
oh no, specific biomarker, no. RAGE has been shown to be expressed in many cancer types, and RAGE actually role of RAGE in diabetes has been studied very well. Like RAGE and advanced glycation and products have a very established role in diabetes. So it's not a specific marker for melanoma.
So if
But
it's not a specific biomarker for melanoma, then what's the therapeutic advantage of targeted RAGE in your case?
it's not specific though, I agree. But as I have shown that all the RAGE ligands that I have shown here are upregulated in melanoma tumors together with RAGE ligands. And it was not known what these together do in melanoma. So here we have shown that RAGE ligands together with RAGE can lead to melanoma tumor growth. Although it's not specific, but in certain population of melanoma patients which have high level of RAGE due to certain reasons, can be benefited with this therapy and with this study. Did I answer your question?
Is this anti-rage therapy only good for those who have already reached that stage where their rage levels are high? Or could it be used before rage levels get that high to try to prevent them from becoming high?
No one actually, there is a paper that has shown that anti-rage antibody can inhibit melanoma tumor growth when there was a baseline level of rage. Yes, that has been shown. But in our case, it seems like when rage is higher, then only it's effective, at least our antibodies.
Varsha, is not rage expressed everywhere?
Oh, everywhere means like all the
Body, pancreas to heart to, and suppose if I'm thinking in terms of the therapy, if you inject antibody, it will filter out, it will go everywhere. So if there is no specificity, because there are a lot of receptors, but not specific everywhere, and people are not successful.
Sure.
So what is the use of this?
Rage has been shown that it is only expressed in embryological development stage. Like in normal healthy adult body, rage is not expressed, except you have any disease like diabetes or cancer. And in healthy body, rage is only expressed in lungs at high level, and it has not been clearly defined what is the role of rage in lungs. It has been shown that it is playing role in lung physiology. But in healthy body, rage is expressed in very baseline minimal level, except you have any
Suppose
disease.
if it is more expressed in the lung, when you inject antibody, it
Mhm.
goes first to the lung because to take
Yeah.
oxygen, the blood goes over there first,
Yeah.
and that's the big filtration mechanism over
Mhm.
there. So how do we think that it will go anywhere else?
Yeah, it will definitely go to lungs, and it has been shown that it goes to lung because the rage in a healthy body, rage is expressed in lungs. But there is not any other tissue where anti-rage antibody will go, because there is nowhere rage is expressed. Rage is only expressed at the disease site, inflammatory site, and lungs. So yeah, it will be diluted to some extent, but still it will go to the.
When it will come to therapy,
Mhm.
I think there will be a serious problem like there are other things people are trying to do and
Yeah.
expressed everywhere, and that's
Yeah. No, but that's the good thing that rage is not expressed everywhere in the body.
So as somebody who's really, really concerned about the lungs, if rage is expressed there, and you said that they're not really sure what it does there,
Well, yeah, yeah.
that would be a very important step, right? So not only will it suck up your drug, your anti-rage antibody, and potentially dilute or decrease the effect that you'd have on your tumor, but there might be off-target that, if you all of a sudden limit the ability of the epithelium of the lung to replace itself, for example, which may be a function just based on what it seems to be doing in your cancer cells, that could be a potentially bad thing. How about, do you know or can you speculate what, if rage is expressed in a human, an adult human, in pathology of diabetes, pathology of cancers such as melanoma, what about a melanoma patient with diabetes?
Oh, okay. Yeah, sure.
What would your treatment do?
No, sure. Before answering this question, let me tell you one more thing that, like you said, that rage has some papers have shown that rage has a protective role in lung cancer actually. opposite effect. In lungs, it has a physiological rise instead of pathophysiological. I wanted to clear
Okay,
this first.
okay.
And regarding your second question, as you said, that in diabetes, yes, there are cases where they have shown that diabetes and melanoma is there in same patient. That they have shown there was a study that the melanoma tumor at the on the foot of patient was misdiagnosed as a diabetic foot ulcer. So there are cases where diabetes and melanoma can come together in a patient. And in that case, I believe RAGE has pathological role in both diabetes as well as in cancer. I think anti-RAGE antibody will influence both of them simultaneously, I guess, because there is not any study that has shown that anti-RAGE antibody treatment in a patient which has both the disease, how it will end up with. But it seems like it will be beneficial for both the disease, because in diabetes, RAGE together with advanced glycation end products leads to activation of certain downstream signaling pathway and leads to further progression of diabetes. And in tumors, other RAGE ligands that are shown as central proteins are. So anti-RAGE antibody can block both the RAGE ligands simultaneously, wherever it will go, and then block both the disease, I guess. Is that what your question was?
Varsha,
Yeah.
I have a comment. To comment on the question of Dr. Zing,
Mm-hmm.
do you have some data which could show whether the antibody, the anti-RAGE antibody, when injected into a mouse, whether this antibody goes to the lung?
Okay, we have done. Yeah, we have assessed the distribution of this anti-RAGE antibody by conjugating our anti-RAGE antibody with Cy5-fluorophore, and we have shown that animals with WM115 RAGE tumors, anti-RAGE antibody could localize more than that of NOC, and it's not going anywhere else, seems like. And yeah, and I have also, this is not a very good graph actually, but we have shown the distribution in different organs, and the distribution was higher in tumors, and yeah, as compared to other organs.
This is the one problem is very prevalent with all those, not only with the race.
Yeah.
Most of the things, if you want to target, that's the problem.
Mm-hmm.
Everywhere these receptors.
Varsha, very impressive array of methods that you use in your studies. I noticed that in your talk here today, and then also in your thesis, you state that we did this and we did that. So can you clarify for us which experiments or which techniques you actually did yourself?
Oh, okay. The animal studies were done by our collaborator. Like, okay, I'll show you how this happened. So, so all those that has this Meghani et al. That has been published. So all these are that I have done it, or even before all this. And after this, Anil and Dr. Law, who were our collaborators, we have provided them with both the transfected cells, and they have subcutaneously implanted these cells inside the mouse body and assessed the tumorigenic potential of these cells. And after this growth assessment study, they have again provided us with all the tumors, and all the further studies that were done with the tumors were, I have done it, this asymptotic array, and all the western blocks, FAP, everything, this ELISA, and this all are, like we have provided him with cells. He produced the tumors, and he gave me all the tumors, and all these studies I have performed them on tumors. First I did it on cells, and then I did on tumors. And later on, these studies were also done, this anti-RAGE antibody, in collaboration with Anil.
So when say in collaboration, does that mean that, did you do any of those experiments?
No. Like this one, no. Like this one, no. Like this one, no.